Okay, if everybody would please take their seats, we'll get started. So today's Lunch and Learn is about advanced techniques and technologies for interventional procedures in medical imaging. The Lunch and Learn is sponsored by Shimadzu Medical Systems. And I learned years ago with Lunch and Learns, one of the key rules of Lunch and Learns is never present anything that makes you lose your lunch. So hopefully we'll satisfy that rule today. So I'm Tim Stevener. I'm the Director of Interventional X-ray Business for Shimadzu Medical Systems. With me today is Dr. Richard Grinstead, who's the Director of Interventional Oncology for Carolina Radiology Associates and McLeod Regional Medical Center. So one of the important characteristics, one of the important problems in imaging, especially in interventional imaging, is we use DSA every day, and yet there's some susceptibility to motion that sometimes you can't overcome, whether it's breathing motion as you see on the left or whether it's the patient movement. When you're using DSA and it doesn't work for you, the question is, what do you do when it doesn't work? What's the choice? Some folks try to drop back to just using non-subtracted imaging, which sometimes doesn't work for other reasons. Or there's a third choice now that is which we've provided from Shimadzu. So we've invented a feature called Score RSM. It is a patented feature by Shimadzu, and it, as we say, defeats motion. It preserves the separation of blood vessels and bone, but also provides some dose reduction and contrast reduction, and I'll show you some of the data that was presented last year in this same session. So RSM stands for real-time smooth mass subtraction, and so this is an old technique that's been modernized for real-time imaging, and it uses a multi-frequency mask to create a maskless DSA. So in real time, it's actually gathering the low frequencies portions of the image and then creating an image which is, as I call, semi-subtracted. So not fully subtracted, but also not susceptible to the problems of a fully subtracted image. So the benefit of that, as you can see on the right-hand side, is with our unique image processing on the same image, the motion from the breathing motion and the bowel peristalsis, along with the other motions that may be in the field, are overcome by being, and it allows you to be able to see the vessels and see the vasculature that would have been otherwise obscured by that motion. So last year in this similar session, one of our important users, Dr. Brian Brown, presented some data. He'd collected some data over 14 patients while he was doing peripheral artery procedures. So he treated 14 patients for calcific PAD who suffered from critical limb threatening ischemia, and he was using our system, the Trinius system. And many of his patients that present to him present with renal insufficiency. So, the difficulty in being able to pass contrast media through the kidneys is something that he has to worry about on a regular basis. So what he did was he wanted to compare what would be the result with regular segmented DSA down the leg with using Score RSM, and he did that on 14 patients. Up until that point, 14 patients. He continues to gather more data over time, but up to that point, 14 patients over a 6-month period. So I'll show you that data. So there's all 14 patients, and basically what it resulted in a dose savings across all those patients by comparing the segmented DSA with the Score RSM DSA of almost 60% dose savings. In addition to that, while he's treating those patients, he's also realizing contrast savings of about 40% because he doesn't have to apply the same amount of contrast while he's trying to run down the legs. So it's simpler and easier to do according to him. His conclusions were that it's faster and simpler to do a single sweep down the leg using Score RSM. He's defeating motion, which eliminates the risk of retakes. And there are clear advantages in terms of savings of dose and savings in contrast that I've already told you about. To quote Brian, he said, RSM gives me more efficiency, lowers my procedure time, and reduces the dose to me and my patients, so why wouldn't I use it? Brian also did a little bit of study with our CO2 imaging because of the renal insufficiency. He decided he needed to explore that using regular DSA. And as you see on this image, there's a CO2 image on the left, and then a CO2 and DSA image comparison of the same retrograde tibial on the right. And what he found was this happened during a time period when you've all probably experienced the shortage in iodinated contrast last year, and he needed to be able to provide another solution. But at the same time, he recognized that with his patients with renal insufficiency, there's a need to be able to choose something other than iodinated contrast in some of these situations. So as you can see, it doesn't look the same as a DSA image, but it does certainly give you the ability to diagnose and treat the patient with CO2, especially when there's no other choice. So also I'll point him out because he happens to be in the audience with us today, Jason Barrett, who did some presentations last year on using our SCORE RSM for interventional radiology procedures. And the goal was really to overcome the breathing motion, the peristalsis, and the patient movement, as I've already mentioned. So in his presentation, he identified a few cases where vessel identification is very difficult when you see the blush of the contrast on the left-hand image. And so it obscures the vessels. And so by using SCORE RSM, you're able to see the vessels very well. Similarly, with the SCORE RSM, when you're looking down in the abdomen, this is the same procedure I showed you earlier, that you're not impacted by bowel peristalsis or breathing motion in the patient. So other clinical examples, when you're moving around, the patient's moving around, patient movement, you see on the left-hand image, you'll see the patient's foot move, which would normally give you a poor result from pixel re-registration, or would require pixel re-registration. And the image on the right, if you were following it, you'll see that the patient's knee, see if I can replay that again. Now, you would see that go back again. You can see the patient's knee move there, and normally that would obstruct the view of the vessels, as you're running down the legs. So once we've defeated motion, then why not introduce motion to be able to create new imaging techniques? And I think following the thoughts of Mr. Barrett, who taught us, that some of the things that they were doing, the fistulogram on the upper left there to find the anastomosis was a good example of moving around rather than moving the patient's arm. You see the hepatic carcinoma treatment in the upper right there, where finding the vessels feeding the tumor became a simpler process and did not necessarily require a spin and more radiation dose to be able to do a cone beam CT. And then at the bottom, you see a UFE, which is often difficult to identify all the outlying vessels that you need to see to embolize. And so by being able to moving around the detector around the patient gives you the ability to outline and lay out those vessels. And then similarly with a pendulum motion, if you're going down in the legs, oftentimes you have to put your hand in the field and turn the leg in order to see the different vessels because moving the patient around is very difficult. But here, just by simply rocking the image back and forth and using motion, you're getting a new imaging technique. We're able to see all those vessels lay out clearly for you. And those images, the vessels are enhanced for your better visualization in addition to that. So I think that shows couple different examples how introducing motion creates different ways of doing imaging that have not been done before. So with that, I'll turn it over to Dr. Grinstead and let him talk about some of the newer procedures he's done and some of the interesting cases that he's accomplished in the last few months. Dr. Grinstead.
Thank you very much. As Tim said, this is Dr. Grinstead. I'm a interventional radiologist, and in all honesty, I've only been using this for about 6 months because I just started at this new hospital system within the last 6 months. So most of my career has been with a traditional DSA using other imaging systems. So as I said, I've only been using this Shimadzu for the last 6 months, and so far I'm very impressed with it. While not perfect, it is another tool in the toolbox, and it does give me very good images for some of the the motion that we typically have to work around, or some of the patient compliance with breathing, or trying to keep still when we're trying to do the traditional DSA. Previously, you kind of live with it. You say, oh, well, that's not a great image, that's not a great picture, we'll have to shoot it again and really try to get the patient to hold still. Or even with a perfect breath hold, a completely compliant patient, you have a bowel peristalsis that can obscure some of the little subtle imaging findings that we're looking for GI bleeds or something along those lines. So my experience with the SCORE RSM drive for experimentation, just being the nature of an IR, you're like, hey, well, what if I do this, or can I try that? So a little bit of a MacGyver experimentation, another tool to use to get the best outcome for the patient. And some of the procedures that I'll be presenting are more body related, rather than like lower extremity PAD runoffs. These are more body focused. So you have the breathing motion, the peristalsis, and things along those lines. All right, so mostly things I wish I knew better, but this is clinical applications and anecdotes. So just kind of my experience. So this first case is a 62-year-old female. We do a lot of fistula work, so she had prolonged bleeding during dialysis, and she had some venous outflow stenosis, but this was her main problem. She had occlusion of the central venous outflow, and during a real-time DSA, there's a question of a small line of contrast along where the superior vena cava should be, but it's right along like the border of the mediastinum. And is that heart motion? Is that a small like aspect of contrast that's squeezing through there? And that's important to figure out how we can best treat this patient, and how difficult like recanalization of the SVC would be. So, is this potentially a little bit of contrast, or, in procedures like this, you hallucinate a little bit because you really want to convince yourself that there's contrast there, and I can get past that stenosis and open this up and fix this lady in kind of one sitting. So it's important to delineate true versus false positives for planning of future procedures. So I did a SCORE RSM, and it showed there was no contrast, no connection to the SVC. That was just heart motion. And so in my mind, planning for the next procedure, it's going to be a more extensive approach to try to get across the stenosis. And
If you want to use the mouse, you can.
Sorry.
The mouse.
Yes. All right. So yeah. So little bit of contrast versus not contrast. And then right here, you can see this is just heart border. It's not contrast. So like I said, in my head, I'm planning a more extensive procedure to do a central venous recanalization rather than just trying to find the small opening of a mostly of a patent vessel versus a completely occluded vessel. So this is a patient with some bleeding. So the CTA showed CTA was positive, so I never take a patient back to do an angio without a CTA. So the CTA was positive. It showed a diverticular bleed in the descending colon. So this is a DSA of the inferior mesenteric artery feeding the region of the bleed on the CTA. And so you have some bowel motion. Obviously, some of this stuff is bowel motion, and it's obvious bowel motion, but you kind of question, is this a bleeding diverticulate? These little blushes here, because that could be peristalsis, that could be the bleed that we're trying to get after. And so I shot RSM of the same location, and you have sharper edges, less blur with the bowel motion, and you can see that on this angio, there's no bleed. There's no blush, no extrav. So the decision was made to not treat this patient, and sometimes that's just as important as trying to treat the patient, right? Sometimes it's better not to intervene, especially in this case where there's very little collateral vessel feeding the descending colon. You don't want to embolize something just because you saw it on a CTA and potentially cause ischemic bowel. So we did not do anything in this patient because I'm not going to embolize something just for fun. So RSM is great, but it's not perfect. In this case, this is a 38-year-old male with bilateral PE. He has a history of newly diagnosed mucinous carcinomatosis that he's very, very newly being worked up for. So they had not yet ruled out brain mets. So they only gave him heparin. He was not on TPA for fear of bleeding in the brain. So we did this conventional DSA with, to delineate the PE, and you can see down here there's filling defect, signifying where the thrombus is. There's some filling defect here, again showing where the thrombus is, and traditionally you can get a pretty good idea of where the clot burden is for normal DSA. And so I did an RSM, and it's not as obvious. Here's some of the filling defects. It's not as obvious with the RSM. For big clots, I shot the right side, and there's filling defect here. There's obvious filling defect into the truncus intermedius and the right upper lobe. So there's clot burden here. So this gives you an idea of where the clot burden is, but again, it's not the stark contrast that you have with the traditional DSA. And kind of my thought process is, well, why is the image not that pretty, right? We saw those very, very pretty lower extremity runoffs where you see the vessel all the way down. You see the good opacification of the vessels. Why isn't it as nice in the pulmonary vasculature? And I don't have an answer for that. I think it's, is it a limitation of the caliber of the vessel? Is this a much higher flow system, so the contrast is washing out faster? I think this is an area for future research and something that can be improved upon. Just to say, there are some limitations for RSM. These next couple cases I think are where RSM does really well. So this is a pelvic trauma patient. I did not do RSM images on this patient. I wish I had, but it was an MVA. Patient had surgery. There's a whole bunch of metallic fixation. He had a pelvic X-fix and a whole bunch of metal in his pelvis. He also had this retroperitoneal bleed and dropping hemoglobin. So the CT showed a retroperitoneal hematoma. Angiogram showed this pseudoaneurysm right here off the internal iliac artery. And obviously the metallic fixation obscures some of the vessels. So if I had shot it with RSM, I still think that you would get some of the metallic fixation hardware. But if I had done here's more pictures of all the fixation hardware. They have a sacral screw, pelvic X-fix. This is a coil pack. We embolize that pseudoaneurysm. but I wish that I had shot an RSM and potentially used the introducing the precession motion to try to look around the metal instead of, you know, just having these vessels behind the metallic fixation hardware obscured. You know, if I shot an RSM and did like the precession where you have the movement, you can kind of look around the metal fixation. I think that this would be helpful in potentially like geniculated artery embo on post-op knee patients. You know, we've had some success with geniculated artery embolization for post-op knee pain. And those are notoriously difficult because the geniculated artery is right behind the knee hardware. So it's difficult to try to see where the origin of the geniculated artery and all the branch vessels are. So if I'm able to do an RSM and introduce the precession rotation, then potentially it cuts down on procedure time, and I'm able to get through the geniculated artery embo faster. So the portal interventions, I think, are 100% uniquely IR. There are, you know, IR overlaps a lot with vascular surgery, cardiology, general surgery, but I don't think any other specialty touches the portal vein, just because it's so difficult to access. You either have to do a TIPS access or a transhepatic access. It's just very difficult to get access into the portal vein, which is why everyone leaves it for IR to do. But this is a patient, status post-TIPS. She had portal vein thrombus. She started having increased velocities on her follow-up ultrasounds and recurrent ascites. So this is a picture showing some portal vein thrombus and filling defects. So this is a kind of a side-by-side comparison of a still image of a traditional DSA picture and a RSM picture. So the DSA, you see this filling defect here, thrombus, and maybe this is either mixing artifact or like some washout. But on the RSM, you can certainly see here's areas of narrowing, here's thrombus, and then even thrombus in the main portal vein helps kind of delineate where the deficiencies in the tip shunt are. You know, there's narrowing, you know, in the inflow. There's some narrowing out here in the outflow. There's a thrombus, you know, in the main portal vein and thrombus into the left portal vein. So it gives a better overall picture of where I need to treat and how I need to treat. You can see in the CINE loop that the patient's breathing, so you don't have that blur artifact with some of these abdominal interventions. So this is a 44-year-old male referred for renal mass embolization. And again, this mass, you can kind of squint your eyes and hallucinate, you know, this little ball here of mass enhancement. This renal mass is terribly poorly identified due to overlying bowel peristalsis and movement and patient breathing, and, you know, yes, you can see it, but it's not pretty. And there's, you know, bowel and there should be a better way to visualize this rather than trying to like hunt around and guess if that's really the target I'm looking for. So this is SCORE RSM that shows it's not quite apples to apples imaging. I got a little bit more selective for these images, but here you can still see, you know, outline of the renal parenchyma. You still get a little bit of the parenchymal blush, but you can really see this superior pulled renal mass much better with the RSN imaging, and, you know, it makes the procedure much quicker, and there's less guesswork as you're going through it. So as kind of conclusions, the advancements in technology have been, we're using those to solve the simple problems, right? Patient breathing, patient moving, injecting contrast into a limb, and contrast burns. It's really hot when it's going into like a foot, so the patient always moves. So trying to take out the patient movement piece and still get good imaging, or introducing movement just to get a better three-dimensional idea of where, vessel origins are, or, looking around metallic fixation or something along those lines. And as we saw in the earlier kind of research bit, lower radiation, less contrast media, you're not having to repeat imaging just to get a better picture. And that's available because of the RSM. And for me personally, it reduces some of the questions, because as you're shooting angiograms, it's like real time. You're trying to synthesize the information and make a call. Like, is that for real, or is that my imagination? Am I hallucinating that because I really want to see a bleed, or I don't want to see a bleed, or whatever the case may be? So it kind of reduces the second guessing, or the questions that come with doing real-time angiogram and trying to figure out if I'm going to intervene or not intervene. As I said before, no solution is perfect. Not every DSA or RSM or whatever is perfect for every procedure, every patient, but it's just another tool in the toolbox. And having just one extra tool to pull out and say, hey, we can try this, or this could be beneficial to achieve the best results for patients and procedures, and just trying to get the best outcome possible, and being able to more confidently diagnose whether something is truly a bleed or truly stenosis versus just artifact. So.
Thanks, Dr. Grinstead. So we're now available if you want to ask some questions. There's a microphone in the center of the room. Feel free to step up to the microphone. Again, any questions from the audience? Okay, then I want to thank all of you. Appreciate you coming. Look forward to seeing you. Please stop by.